Hello everyone and welcome to the fourth in the series of UCARE educational videos dealing with the 7 C's in the diagnostic workup of chronic spontaneous urticaria. Today we will be talking about the potential biomarkers or predictors of treatment response in CSU. I'm Dr. Ramzy Mohammed Ali, consultant allergy and immunology, and I have with me Dr. Tayseer Ibrahim, who is also consultant in allergy immunology. We are from the UCARE Center at Hamad Medical Corporation in Doha, Qatar. Welcome, Tayseer.
Thank you, Ramzy.
So, Tayseer, can you tell us what are biomarkers and why do we need biomarkers in chronic spontaneous urticaria?
Okay. Biomarkers or components are objectively measurable indicators that link disease endotype with phenotypes. Biomarkers in general for any disease, it can be used to define phenotype, endotype. It predicts and evaluates response to specific treatment and monitor different aspects of a disease. The characteristic of an ideal biomarker is that it is highly sensitive, highly specific, reproducible each time when you check it, and easily measurable in each hospital, and valid for every patient with a certain condition, but we don't have this all the time. Currently in CSU, for diagnosis and monitor response of treatment, we depend on history and patient-reported outcome. The main limitation of these is their subjective natures, so we are trying to find objective parameters like biomarkers to allow assessment and monitoring of different aspects of CSU. Initially, let me introduce you to the concept of disease phenotype and endotype. So the disease is defined by presence of diagnostic and clinical criteria. The phenotype is observable clusters of features like demographics, triggers, and symptoms response to treatment. And the endotype is defined the molecular mechanisms that drive the disease phenotype. The importance of this in standard medicine, all patients who had one diagnosis and similar presentation, they will be treated the same. And among these patients, some do respond to the treatment and some they do not respond. But if we apply the precision medicine by phenotype and define phenotype and endotype of the disease, we will be able to target the mechanisms that drive the disease, and hopefully we will get for effective treatment for each patient. So in chronic spontaneous urticaria, what we have been trying to use biomarker for is to define disease phenotype and endotype and monitor the treatment response. Ramzy, please, can you tell us about the phenotypes of CSU?
So chronic spontaneous urticaria has 3 phenotypes. Patients may present with isolated wheals, isolated angioedema, or a combination of wheals and angioedema. Patients presenting with isolated angioedema constitute a minority of patients, with patients presenting with wheals or a combination of both constituting the majority. Chronic spontaneous urticaria is predominantly a mast cell-driven disease. Based on the underlying mechanism by which the mast cells are activated, they can be divided into autoimmunity type 1 or autoallergic chronic spontaneous urticaria, autoimmunity type 2B or CSU type 2B, and chronic spontaneous urticaria due to unknown cause, where the cause is yet to be determined. In autoimmunity type 1 or autoallergic CSU, IgE autoantibodies act against self-antigens like anti-TPO or IL-24 or other self-antigens, in turn leading to the stimulation or activation of the mast cells and degranulation. In type 2B autoimmune CSU, IgG autoantibodies act against IgE or the high IgE anti-affinity receptor Fc epsilon R1, leading to mast cell activation and degranulation. Type 1 autoimmune CSU is more common compared to type 2. The studies which have looked into the biomarkers for CSU have largely focused on differentiating the 2 endotypes. They differ in several important clinical or laboratory features, and they also differ in their response to treatments. Previous studies have found elevated IgE anti-TPO in a lot of patients with chronic urticaria. These IgE anti-TPO may not be able to be measured commercially, or there are no standardized options to measure IgE anti-TPO. Elevated IgE anti-TPO has also been found to be largely associated with autoallergic chronic spontaneous urticaria. Recent studies which have looked into the association of positive anti-TPO and chronic spontaneous urticaria have found that patients who had positive IgE anti-TPO have a higher rate of atopy and they had higher IgE levels. Hence, these markers may be used to identify patients with type 1 autoimmune chronic spontaneous urticaria. Type 2 endotype constitutes around 10% of the patients when strict criteria are applied. They are more common in female patients. These patients are characterized by a higher disease severity. They may be associated with autoimmune diseases like Hashimoto's thyroiditis, vitiligo, and type 1 diabetes mellitus. The recent Corsa study, which had looked into the components in autoimmune chronic spontaneous urticaria, had found that these patients often had more associated angioedema. They had frequent nocturnal symptoms, and most of these patients had symptoms more than 5 days in a week. The PURIS study was the first study to assess the 3 defining criteria in identifying patients with type 2 autoimmune chronic spontaneous urticaria. These include a positive IgG immunoassay, a positive basophil activation test, and a positive autologous serum skin test. The PURIS study had looked into around 182 chronic spontaneous urticaria patients, and they found that all 3 parameters, diagnostic parameters, were positive in 8% of the patients, thus truly identifying type 2 autoimmune chronic spontaneous urticaria only in 8% of the patients. They also had looked into the ratio of IgG anti-TPO to total IgE, and they found that a significantly large amount of patients with autoimmune chronic spontaneous urticaria had elevated IgG anti-TPO to total IgE in comparison to those who had partial autoimmune chronic spontaneous urticaria or non-autoimmune CSU. The combination of elevated IgG anti-TPO and low IgE levels have also been linked to most of the diagnostic markers of autoimmune chronic spontaneous urticaria. They have been found to be strongly associated with a positive autologous serum skin test, a positive basophil activation test, or low eosinophil and basophil levels, more so in compared to either elevated IgG anti-TPO alone or a low IgE level alone or normal anti-TPO IgE levels. What is the role of eosinophils in chronic spontaneous urticaria? Eosinopenia has been found to be associated with the type 2 endotype. They are characterized by a high disease activity. These patients may have associated low basophil counts. They may have positive autologous serum skin test or a positive basophil histamine release assay. They may have high IgG anti-TPO or low total IgE levels, which have all been found to be markers of type 2 autoimmune chronic spontaneous urticaria. So Tayseer, can you tell us what biomarkers have been used to assess the response to guideline recommended treatments and to how to differentiate the response in the 2 endotypes?
First, let me remind you with the recent guidelines for treatment of CSU that recommend to start with standard dose of second-generation antihistamine. If no symptoms control, then to increase the second-generation antihistamine dose to up to 4 times. And the second line is Omalizumab. If still there are poor symptoms control, Omalizumab dose can also be increased or shorten the interval between doses to achieve better control. If no adequate symptoms control with Omalizumab, the third line will be adding cyclosporine to second generation antihistamine. For second generation antihistamine, these biomarkers, they were found to be linked with poor response to antihistamine, like autologous skin serum test positivity, high D-dimer, high disease activity measured by Urticaria activity score, high CRB and low blood basophil and eosinophil, elevated IgG and TPO, which all have been linked to type 2B autoimmune CSU. Also, presence of concomitant inducible urticaria and previous steroid treatment is also found to be linked with poor response to antihistamine. In this study, we can see that patients with low eosinophil level, they were having poor response to second generation antihistamine. Also, using the combination of presence of IgG and TPO and IgG, low IgG level was linked to good response to antihistamine compared with patients who have no normal level of anti-TPO IgG or IgG level. Here also, if we have seen the relationship between D-dimer level and response to second generation antihistamine, here 1 is a good response and 5 is poor response. So the higher the D-dimer, the patient will have poor response or no response to second generation antihistamine. Regarding CRP and D-dimer, they were also linked with urticaria activity, disease activity. So presence of high CRP and high D-dimer, as we saw before, it is associated with poor response to antihistamine. And presence of high CRP is positively correlated with disease activity. And presence of basophil is negatively correlated with disease activity. So if the patient have high blood eosinophil level, the disease activity will be low. So Ramzy, please tell us about the biomarkers for response and no response to Omalizumab.
Similar to the biomarkers that have been looked into to differentiate the two endotypes, these biomarkers are also being used to assess the response to Omalizumab. The non-response to Omalizumab has been found to be associated with a low total IgE, high IgG anti-TPO or their combination, a positive basophil activation test, the presence of low eosinophil or basophil counts, which are all markers of type 2 autoimmune chronic spontaneous urticaria. History of previous immunosuppressive treatment or low basophil Fc epsilon R1 expression have also been associated with a poor or a delayed response to Omalizumab. IgE is one of the most promising biomarkers that are available, and it's also widely available for use for testing. High IgE is good and low IgE is bad. So the study, which was conducted by Weller and colleagues, looking into the response of Omalizumab in relation to IgE levels, found that in complete responders, 80% of the patients had a high IgE level in comparison to 80% of the non-responders with a normal or low IgE level. Rajib Ertas also had looked into the relation between IgE levels and their change in patients who were started on Omalizumab for chronic spontaneous urticaria. They found that non-response to Omalizumab could be predicted by low baseline total IgE levels. Also, that low IgE level less than 43 had shown a 33% risk of non-response to Omalizumab after 12 weeks of treatment initiation. A ratio of week 4 IgE to baseline IgE was found to be a good predictor of response to omalizumab. That is, if a patient had a higher baseline IgE level and a week 4 IgE was more than 2 times the baseline IgE, they had a 90% or more chance of responding to omalizumab. Whereas patients who had a low baseline IgE level and the week 4 IgE post omalizumab initiation was less than 2 times the baseline IgE, they had only around a 30% chance of responding to omalizumab. So a 2x4 rule could be applied as a biomarker to assess response to omalizumab. As we saw earlier, IgG anti-TPO to IgE is a marker for type 2 endotype of chronic spontaneous urticaria. In this recent study, which was published in WOW, looking into the outcome of omalizumab treatment in patients with chronic spontaneous urticaria, they found that the patients who were non-responders to omalizumab had a higher median IgG anti-TPO to total IgE in comparison to patients who responded to omalizumab treatment. In the same study, they found that higher IgE level at baseline was associated with a chance of relapse after stopping omalizumab. However, these patients, when they were reinitiated on omalizumab treatment, they had a rapid response. A basophil histamine release assay or autologous serum skin test positivity has been associated with a delayed response to omalizumab. This study had shown that patients who had a positive BHRA or ASST positivity, they had a 4 to 5 times more likely to have a slow response to omalizumab compared to patients who were BHRA or ASST negative. A median time to respond of 29 days or more were seen in patients who were positive to either BHRA or autologous serum skin test positive. In this study, they found that the relation between checking the relation between eosinophils and omalizumab, they found that patients who were non-responders had a lower eosinophil count compared to partial or complete responders. They also found that after treatment initiation with omalizumab, 1 month after first or the second dose, the eosinophil count remained to be low in patients who were non-responders, more and so compared to patients who were partially or completely responsive to omalizumab. There are certain factors that have been found to be associated with omalizumab resistance. These include a high sensitivity CRP more than 3. Obese patients with a BMI of more than 30 have been found to be associated to have a low response, or they may require higher doses of omalizumab. A worsening of chronic spontaneous urticaria after initiation of omalizumab and prior use of immunosuppressants have also been associated with non-response or poor response to omalizumab. So Tayseer, can you tell us what biomarkers have been used to assess the response to cyclosporine?
Presence of low total IgE and positive basophil histamine release assay, which were linked before to type 2 B autoimmune CSU, were found to predict good response to cyclosporine treatment. Here we can see that those patients were started on cyclosporine for their CSU. They found that the response rate was higher on those who have low total IgE. Similarly, patients with positive basophil histamine release assay, they achieve a complete response in 81% compared to 19% only who have negative basophil histamine release assay. It is not only the response, but the response in those patients was seen as fast as 5 days compared in patients with positive basophil histamine release assay compared to those who had negative test. So let us try to put this into practice. Can you tell us, Ramzy, please, how to use these biomarkers in diagnosis of CSU endotypes?
So the diagnosis of type 2 autoimmune CSU has been well summarized in this algorithm, which was published in a recent article in JACI. Once a patient presents with chronic spontaneous urticaria, look for the possible risk factors associated with type 2 endotype. These include female sex, patients who have a higher disease activity, patients who have associated autoimmune diseases, a poor or non-response to antihistamines or Omalizumab. If these risk factors are present, then consider doing a basophil activation test. If positive, look for the other markers which we had discussed for type 2 endotype of autoimmune chronic spontaneous urticaria. If one or more markers are present along with the positive basophil activation test, most likely we are dealing with type 2 autoimmune chronic spontaneous urticaria. If they are negative for these other markers and positive for a basophil activation test, or a basophil activation test is negative, but one or more other markers are positive, then the type 2B autoimmune chronic spontaneous urticaria may be a possible diagnosis. However, a negative basophil activation test or negative for other markers to assess type 2 endotype and the absence of any risk factors for type 2 endotype, then they were unlikely dealing with type 2B autoimmune chronic spontaneous urticaria. This slide summarizes the difference between the two endotypes. So patients who have autoallergic chronic spontaneous urticaria are more common, constituting around 70 to 80% of the patients. They may have associated allergic conditions. They may have a high or normal IgE level. And these patients usually have a high chance of responding to Omalizumab, and the response is usually rapid. Type 2 endotype, on the other hand, these patients have a longer disease duration from the onset of symptoms. They may have associated autoimmune diseases. They may have elevated CRP levels. They may have a higher rate of eosinopenia or basopenia. They may have low total IgE levels or elevated IgG anti-TPO or a combination of both. They may have associated autologous serum skin test or basophil activation test or basophil histamine release assay positivity. These patients usually have a poor or a delayed response to Omalizumab. However, they have a good response to cyclosporine. So Tayseer, can you summarize what we know till now about the use of biomarkers in chronic spontaneous urticaria, and what are the unmet needs or future for biomarkers in chronic spontaneous urticaria?
Till now, that the proposed causes of CSU are type 2, type 1 and type 2B autoimmunity. Both endotypes, they may coexist in the same patient, or you might find patient with only one endotype. However, both endotypes, they have the same phenotype of wheals, angioedema, or both, as we see before. And type 1 and type 2B autoimmune CSU, they have different disease course. They have different clinical features and response to treatment, as we saw before. What we need to learn or to look more for is to try to identify the molecular mechanisms of both endotypes and to characterize the mechanisms behind spontaneous remission of CSU, and to document the epidemiology of CSU with type 1 and type 2 autoimmune CSU, and both or the new phenotype which lacks the features of both these endotypes, and to develop diagnostic biomarkers that is easily to be measured and available in all centers, that will help us to diagnose these endotypes and to follow the treatment response and to follow the disease course. Thank you.